next speaker is Dr. John Yoon. Dr. Yoon is an academic hospitalist physician, very interested in the moral and professional development of medical students and residents. He's a co-investigator on something called the Project on the Good Physician. And today, Dr. Yoon will speak to us about operationalizing the virtues for good doctor-patient relationships. John.
Well, on behalf of my colleagues in the Project The Good Physician, I'm delighted to have this opportunity to speak, and I'm grateful for the Bucksbaum Institute for their generous support of the study as well. This project grows out of an ancient question, very much at the heart of our day-to-day experiences as medical educators who are tasked with forming good physicians. And here Plato asked, can virtue be taught? Or if not, does it come by practice? Or does it come neither by practice nor by teaching, but by nature or in some other way? Now, I don't know if Plato thought anyone would have the audacity to try to create studies to answer this question, but I guess we did. But the empirical research that would have the most power to help answer this question would involve studying nationally representative cohorts of physicians from matriculation to medical school to several years out of practice. No such study has ever been done in the US, but to lay the groundwork for it, we conducted a pilot study which I will present to you now. In this pilot study, we surveyed a nationally representative cohort of about 960 medical students across 24 US medical schools. We surveyed this cohort at 3 time points, once in their 3rd year and then once in their 4th year. And we also conducted qualitative interviews of a subset of these participants to better understand their medical experiences. And though I won't address it in this talk, we also had a peer rating module in which we asked students to rate each other on various attributes, and this was used to help validate some of the self-reported virtue measures we were developing in this project. Again, time doesn't permit me to discuss the various findings of this project in detail, but I'll just briefly mention that we investigated a variety of research topics, including assessing for obstacles to medical virtue, which we thought included burnout and entitlement. We assessed for facilitators of medical virtue, including experiences of moral elevation while working with clinical exemplars. This survey also contained measures of physician well-being, basic demographics, as well as moral, religious, and personality characteristics. But in particular, we focused on 3 virtues deemed theoretically central to the formation of good doctor-patient relationships, including empathy, mindfulness, and interpersonal generosity. And we included prominent measures of each from the psychology literature, and we adapted these measures to create medicine-specific versions. These are the demographic characteristics of our sample, and our sample appears to be representative of the US student population when it comes to sex, region, and race, ethnicity. And as you can see, our sample contains students from schools across a whole spectrum of social mission score rankings. And in case you're not familiar with the social mission score, medical schools are expected to have a social mission to train physicians to care for the population as a whole, taking into account such issues as primary care, underserved areas, and workforce diversity. For example, schools with social mission scores ranked top in their category are designated as school with high social mission, while those ranked at the bottom are considered to have low social mission. And I mentioned that just to give you a taste of the wide range of analyses that we can do with the data we collected. For example, here in this first slide, we attempt to track changes in students' intentions to practice among the underserved between their 3rd and 4th year. At the top, we have students with a high sense of calling in the practice of medicine who also happen to come from schools with high social mission. And at the bottom, we have students with a low sense of personal calling and who also come from schools with a low social mission. And the dark blue color on the left side represents the percentage of those who are consistently reporting over the 2 time points that they do not intend to practice among the underserved. And the next section represents those who initially said they intend to do so, but then changed their mind against it later. And the lighter shade section represents those who have maintained their intentions over time, while the lightest shade section on the right represents those who expressed no intention at first, but then changed their minds and developed a new intention to practice among the underserved over time. And so as you can see at the top, students with a high calling coming from high social mission schools are more likely to maintain or develop new intentions to practice among the underserved compared to students with low calling from low social mission schools. So I bring this up only to show the kind of examples of analyses we hope to undertake with this data. And my particular interest is trying to understand how personal characteristics and environmental characteristics come to play together as they shape students' long-term professional development. In another kind of analysis, we examined whether our self-rated measures of virtue were associated with other, perhaps more objective indicators of virtue. And as we learned earlier in Dr. Gold's lecture, many medical schools have what is called a Gold Humanism Award, in which peers and faculty nominate individuals in their class who most exemplify characteristics of a good humanistic doctor. So here we see that students in our study who were nominated to this award tended to have higher scores in all of the virtues that we assessed, including generosity and empathy. I should reiterate that all of these results are from cross-sectional analyses, so we want to be cautious about inferring a causal relationship. Nevertheless, they suggest some intriguing hypotheses to test as we move into analysis of the longitudinal data. As I mentioned earlier, our study also examined potential facilitators to the development of virtue, and in particular, I was interested in the impact of exemplars or role models in medicine. Recent empirical work in the field of moral and positive psychology, led by Jonathan Haidt, are starting to demonstrate that experiences of moral elevation while working with exemplars can serve as an impetus for a variety of pro-social behaviors and decisions. So to examine the relationship between moral elevation and virtue among medical students, we told students, among the physicians you have known personally, think about the one you most admire as a physician. And we then asked them a series of questions from a moral elevation scale. And these questions included, how often do you feel admiration for this person? And how often do you feel the desire to do good for other people when you're with them? This slide shows that students who report higher frequencies of moral elevation also tended to have higher scores on the virtues, particularly with generosity and empathy. As I also mentioned, we've conducted qualitative interviews with a subset of participants. And in this case, we interviewed those who experienced high levels of moral elevation during their medical training. And thematic analyses revealed consistent themes of students' strong admiration of role models and the desire to emulate them. Some representative quotes include, I think it gives me a role model I strive to become. I think it's fair to say that he's a kind of one of those physicians that most physicians want to be when they grow up. I'd like to think that when I finish my training that I'm able to be that same conscientious, respectful physician who really works on the patient-physician relationship. Or another student said, I was just watching how he interacted with people, trying to model that and remembering the way he phrased things and the way he presented himself to the patients in the situation. We also interviewed students who experienced low levels of moral elevation during the medical training, and some representative quotes include, he just literally did not say one word to me and didn't acknowledge my presence. That's who I didn't want to be like. I think maybe his medical training was horrible, and that's why he was. Maybe that is what he went through, but it's hard to say. Or another student mentioned, I've come across physicians who do things in a certain way that I would not want to. So piecing that together, I've kind of gotten bits and pieces of people who have inspired me to be the opposite of the way that they are. Interesting to me, some students expressed experiences with negative role models, as you see here, that fortunately had the effect of leading them to avoid emulation of their negative role models, while some saying that these negative experiences actually inspired them to be better doctors in contrast. So that gives a brief snapshot of our work to date, and our work provides support for some theoretical reflections by Linda Zajewski, who in her paper writes, we find the admirable attractive in a way that given certain conditions, we would imitate or emulate. So the admirable is what we might call the imitatively attractive. We do not always have the desire to imitate because imitation is often incompatible with our own situation or abilities, or is incompatible with something else we want. But there is an attraction that makes imitation the natural thing to do given the right conditions. The power to move us is present in the motion of admiration. So our findings may support elements of her theory in which admiration and the desire to imitate an attractive clinical exemplar might be serving as the hidden power to move students to be good doctors. This power to move might be harnessed through thoughtful longitudinal models of professional formation that integrate the life experiences of exemplars and role models into the formal curricular experiences of students. In fact, findings from this study led me to launch an undergrad course directed at our pre-meds here in the college. And actually, I think some of them are here, so I should be giving them extra credit. In this class, we've been inviting clinical exemplars and role model physicians to share their stories in their quest to becoming good physicians here at the University of Chicago. And as Dr. Lowenstein shared, I also believe in the power of narratives and stories, especially their formative power in shaping students. And I have to say that I've personally experienced much moral elevation as a result of listening to their stories. So I'm also here because I'm trying to reach out to members of the faculty members of the audience who I might hope might come and speak for the course later on. So in closing, I have to say I'm just grateful for the initiatives like the Bucksbaum Institute that aim to nurture an environment of here at the University of Chicago that I believe moves many of us toward a culture of clinical and professional excellence. So thank you for the opportunity to speak today.
Questions for John about his paper or study?
Well, I mean, in that one quote that I mentioned by Lindsay Zayevsky, she mentioned that under normal given circumstances, positive circumstances, we want to imitate those who sort of show us sort of the ideal. We also want to be able to implement our sort of ideals, but there are certain circumstances where it's hard to do so. And I think burnout is one of those situations where it's hard to practice when you're feeling burned out, right? And I think one of the master clinicians today mentioned about the importance of work-life balance. So I'm not sure if I sort of share your concern about the causal, of sort of implying causal relationships with that. But I think one of our faculty role models who came to speak in my course sort of mentioned that medicine is hard, but everyone needs a place to recharge so that we can get back to sort of our calling and ideals. So I thought he had some insights about that.
Part of the reason why I'm concerned is kind of blame the victim type logic. But
Okay.
The second thing is because the implicit antidote is not just work-life balance, it's
Right.
letting people like take it easy. And I think intrinsic suffering, being with patients who are dying, helping them bear their suffering,
Right.
is never going to be easy, and it shouldn't be.
Right.
So for me, there are other solutions like supporting people as they're living through these hard experiences. Some of the kind of comments that Jerry made earlier about acknowledging the existential component of medical training.
Right.
So I'm worried about overly simplistic thinking
Right.
as these causal connections are drawn.
Well, I really resonated with Dr. Lowenstein's sort of program of allowing students to have that open space to share what they've been experiencing. And I think that plays a very cathartic and therapeutic role in sort of their professional development.
John, thank you.
Thank you.
The highlight of the afternoon, our great medical students. The next set of three presenters will be second-year medical students at Pritzker, who were selected from a very competitive pool of more than 40 applicants as Bucksbaum Institute student scholars. Our first presenter will be Annie Lauer. Annie graduated magna cum laude from Notre Dame in 2007, majoring in English literature and minoring in French literature and international peace studies. As a medical student, under the mentorship of Dr. Niranjan Karnik, who I see is in the audience, Niranjan, Annie has researched the effects of homelessness on the mental health of Chicago's homeless youth. Her talk today is entitled Psychiatric Disorders, High-Risk Behaviors, and Chronicity of Homelessness in Chicago Youth. Annie.
Thank you very much. Thank you. Can you hear me? Okay. So to begin with a little bit of background, youth, a category defined here as about 13 to 24 years old, have the highest prevalence of homelessness among all age groups in the United States at an estimated 9 to 15%, meaning that each night somewhere between 1.6 and 2 million youth are without stable housing. Youth homelessness is associated with myriad adverse effects, including poor physical and mental health outcomes, irregular nutrition and sleep, a lack of economic and emotional support, high rates of abuse and trauma, higher school dropout rates than their peers, high rates of high-risk behaviors, and high rates of mortality, particularly from suicide, trauma, and overdose. For half of these youth, homelessness currently continues into adulthood, and so researchers have highlighted the need for better characterization of subgroups within the homeless youth population so as to have more information to provide more targeted and effective interventions. So some relationships between risk factors and adverse outcomes have been explored in previous literature. So you can see that increased length of homelessness, a measure of duration, has been correlated with increased substance use, as well as increased high-risk sexual behaviors. Youth who are homeless are more likely to have an earlier sexual debut, to engage in unprotected intercourse, and use drugs or alcohol prior to intercourse. Furthermore, earlier age at first homeless episode has been shown to be correlated with increased high-risk sexual behaviors and increased number of psychiatric diagnoses. And substance use itself has been shown to independently correlate both with increased number of psychiatric disorders as well as increased high-risk sexual behaviors. However, many of these relationships are complicated, have been debated, and merit further study along with consideration of other questions. First of all, most studies that have looked at duration of homelessness in the past have looked at it as like a bimodal variable. So longer than 6 months homeless would be long-term homeless, and shorter than 6 months would be short-term. So we asked whether looking at time as more of a continuous variable would provide new insights. Furthermore, frequency is a measure that's not been significantly treated in past studies. So we asked whether youth who are more frequently homeless, perhaps in and out of homelessness, may be somewhat of a different group than youth who are homeless for longer periods of time. Therefore, the purpose of this study was to gather data and analyze it from a Chicago homeless youth population, and to characterize the prevalence of the adverse outcomes that I listed on the previous slide, and to see whether the relationships, as demonstrated on the previous slide, hold in our population. Furthermore, it was to incorporate time as a continuous variable in terms of duration of homelessness, and add frequency as we analyzed the data to see whether it yielded new insights. So 66 youth were recruited from 2 homeless shelters in Chicago, the Night Ministry in Westtown, and the Teen Living Program in Bronzeville. Both organizations provide short-term and emergency housing to youth. Youth who completed the informed consent process were administered the Mini International Neuropsychiatric Interview, which allows for the assessment of major psychiatric disorders and substance use disorders via a semi-structured interview. Furthermore, they completed an excerpt of the CDC's 2011 National Youth Risk Behavior Survey, which inquires about high-risk substance use behaviors as well as high-risk sexual behaviors. As compensation, all youth received a $10 gift card, as well as a copy of their more in-depth final report, which included a complete neurocognitive assessment that could be used to demonstrate need for supportive services in an academic setting, and was part of a kind of a second branch of the study. And then we analyzed the data. So to provide you with just kind of some overall population demographics, the average age of our participants was about 19 years old. About a little over half were female, and the majority, about 80%, were African American. Most youth had been homeless between 1 and 3 times in their lives. Next, the prevalence of psychiatric diagnoses among the sample are listed in this table. I obviously don't have time to go through all of it, but just to point out a few things. There was a high prevalence of psychiatric diagnoses in the sample. Almost 82% of youth met criteria for at least one psychiatric disorder, including about 66% for a mood disorder, 34% for an anxiety disorder, and almost 8% for a psychotic disorder. Furthermore, if you look in the bottom right-hand part of the screen, you see that almost 30% of youth met criteria for either substance abuse or dependence, and almost 20% for alcohol abuse or dependence. These elevated rates are consistent with previous studies. Next, we analyze time, the time variables, so onset, duration, and frequency of homelessness, both the time variables with each other as well as with the number of psychiatric diagnoses per participant. And you'll see that I've highlighted significant correlations in the red boxes. Early onset of homelessness has an inverse significant relationship with total lifetime episodes, which is the measure of frequency, as well as the length of the longest episode, which is a measure of duration, meaning that youth who are younger at their first episode of homelessness were significantly likely to experience longer and more frequent episodes of homelessness. Furthermore, both increased frequency and duration of homelessness were associated with increased number of psychiatric disorders per participant. Next, the CDC Youth Risk Behavior Survey data was converted into 5 risk scales. So smoking, alcohol, marijuana, hard drug, and sexual behavior risk scales. And to point out, so again, the significant correlations are highlighted in the red boxes, and you see that earlier onset of homelessness was associated with the higher score on the smoking risk sum. But the factor that emerged as most significant, actually, was increased frequency. So youth who are homeless who are more frequently homeless were actually more likely to have high risk behavior scale scores in smoking, marijuana, and hard drugs. The fact that frequency emerged as significant and the most significant time variable supported the importance of using it when analyzing such data. Furthermore, I'd like to point out that increased number of psychiatric disorders was associated with increased scores on all 5 of the risk scales. As this was a cross-sectional study, we were unable to draw conclusions about causality, although it appears that this would likely be a bidirectional relationship, and at least in some part may reflect coping mechanisms for psychiatric pathology. Finally, we analyzed individual psychiatric disorders based on each of the time variables. So here you see 4 of the significant disorders that emerged for earlier onset of homelessness. So on the y-axis, you see mean age in years, and then you see the 4 disorders on the x-axis. So for example, youth who met criteria for major depressive episode were significantly likely to be younger at the first onset of homelessness than youth who did not meet criteria for the disorder. These 4 disorders, major depressive episode, as well as panic disorder with agoraphobia, post-traumatic stress disorder, and alcohol abuse or dependence, are not particularly surprising given the traumatic experiences that youth reported having gone through on the streets, and furthermore considering that youth homeless at a younger age would theoretically have had less time to develop effective coping mechanisms. Interestingly, when the same analysis was done on with the other two time variables, so increased duration and increased frequency of homelessness, different psychiatric disorders emerged as significant. I won't read them all to you now, but analysis of this preliminary data emerging with 3 somewhat different profiles suggested that analyzing data by the different time variables may be helpful, and we'll be interested to see whether these same significances continue to hold when we analyze our final data set. Finally, this study did have limitations. Its cross-sectional nature prevented us from drawing conclusions about causality, and the fact that we only worked with 2 shelters may have in some ways artificially narrowed our population based upon the requirements of those institutions. However, we're continuing to perform data collection, are partnering with other organizations, and are looking to work with the mobile van unit, and we're hoping that the final data set's larger size and diversity will help us to minimize the effects of bias. Therefore, this study of a Chicago homeless youth population did identify a high prevalence of high-risk behaviors and psychiatric disorders, which is consistent with previous studies. And furthermore, analysis of time as a continuous variable, as well as inclusion of frequency in our analysis, seemed to be helpful in identifying possible different subgroups within the homeless youth population, with the eventual goal of just understanding subgroup risk factors better, with the hope of being able to effectively design interventions in the future. I'd like to thank my mentor, Dr. Niranjan Karnik, and Dr. Hunter, the other co-investigator on the project, as well as the research team and the Bucksbaum Institute for giving me the opportunity to speak. Thank you.
Are there questions for Andy Lauer? Peter.
Was this group a fairly literate group? It's a self-administered questionnaire, right?
Well, it's the interviews, or the interview that this is based on was a series of that's a great question, was a series of questionnaires. So some of them were administered by us, some of them were administered, it was really like the kind of high-risk behavior, self-reported data that was designed by the CDC to be used in this population and age group for like a national population. So I think it's worth considering that may have affected responses, although it was designed, like the high-risk behavior questionnaire part was designed for this population, and so I think was fairly well understood.
Okay.
Yeah.
Arthur.
Yeah.
I remember in some other studies that these individuals at high risk for substance abuse also have a high prevalence of HIV. And I wonder if you have any data on that kind of analysis.
Well, I certainly, in doing kind of my background research, preparing, I certainly read a lot of studies that looked into that. I don't have, that was not the focus of this particular part of the study, and so I don't have any data on that right now. I think as a proxy, the high-risk sexual behaviors may in some way speak to that, but not specifically about HIV.
I was just going to ask the question about the correlations and the associations. Is it not possible that the psychiatric diagnoses drive the characteristics of homelessness that you described rather than vice versa?
I think that's a very good question, and I think, because it's a cross-sectional study, it's impossible, that's not kind of necessarily the question that this study is going to answer, although I think it seems likely, in having kind of just having gotten the chance to interview youth and talk with them, I think that probably it's a bi-directional relationship, and it depends a lot on the person and their situation. So for some people, becoming homeless or the experiences that they face once homeless may have precipitated underlying risk factors and caused, decline in mental health, whereas maybe it was the vice versa for other people. And
Excellent.
Yeah.
Thank you so much. Our next speaker will be Elizabeth Ryan-Smith, who graduated magna cum laude from Harvard in 2005, majoring in economics and health policy. Elizabeth has served as the co-coordinator of the Washington Park Children's Free Clinic, a student-run clinic for underserved children. Under the mentorship of Dr. Bill Meadow and Niti Pinto, Elizabeth has conducted research on the accuracy of prognoses regarding patient outcomes in the pediatric intensive care unit, and that's the work we'll be presenting today. Elizabeth.
Thank you so much, Dr. Siegler, and thank you to the Bucksbaum Institute for allowing me to present today. So first, I just want to talk about why we studied prognostication in the pediatric ICU. I think it provides a very unique, challenging situation for the doctor-patient relationship. I'd like you to imagine a scenario that's basically a consolidation of several patients in our study. A child is admitted to the pediatric ICU with a brain injury. They have a complicated course. They have setbacks across multiple organ systems, but also some improvement. Both their survival and long-term outcome are uncertain, and yet the parents must decide on invasive procedures that may involve technological dependence for the child that may be difficult to undo if there's a different choice to be made later. So basically, parents or guardians of these patients must make life-altering decisions based on limited information. Functional prognosis is also important to families. They've done qualitative studies of pediatric ICU families, both of patients who survived and who did not survive, and they said that honest communication from the physician was very important to them. There are currently some score-based measures of severity, such as the PRISM, for use in the ICU, but these are purely for mortality rather than for functional outcome, and they're also based on the initial time point of admission, where we know that the clinical picture can change over time. We also believe that the clinical intuitions of these care providers impact family meetings and medical decisions, even if they're not explicitly stated. Other studies have shown that there are limitations in a clinician's ability to predict mortality and functional outcome in ICU settings. And basically, predictions of death before discharge in both the neonatal and medical intensive care units were incorrect approximately 50% of the time. So our objectives were to explore the accuracy of these clinical predictions of mortality and functional outcome in the pediatric ICU, and to compare these prediction positions of functional outcome to objective measures and perceptions. And our hypothesis was that the intuitions in general would be no better than chance, but may improve if you look at the care team as a whole and agreement across the care team and predictions over time. And we expected limited ability to predict functional outcomes. What I'll be presenting to you today is a preliminary analysis of our first patients from the previous summer. We are doing 6-month follow-up with our patients that is continuing ongoing. So this is a single center prospective cohort. We enrolled 143 patients for continued follow-up. Again, I'll be speaking about our preliminary patients. We had 28 patients for 1-month follow-up from this summer. We gathered almost 1,500 clinical intuitions over 428 patient days. And again, I'll be speaking about those 28 patients. So in our study population, we had 110 patients for whom we knew mortality figures, and then 28 patients for whom we had our 1-month follow-up. And you'll see for our patient demographics, 104 survivors, 6 non-survivors. The average age was early school age. And you'll see that for survivors versus non-survivors, there is a slightly longer length of stay, which you might expect. For our methods, each day of the patient's stay, we asked each member of the care team, attending, fellow, resident physician, and bedside nurse 2 questions. Do you think your patient will survive to hospital discharge? And we asked them to rate their confidence in that. And if yes, do you think this patient will have no, mild, moderate, or severe functional impairment at 6 months? And we also asked them to rate their confidence. In terms of follow-up, we did telephone interviews with parents. For this is 1 month post-discharge, but for our long-term is 6 months post-discharge. And we used those interviews to rate the patient on a functional status score, which rates across 6 dimensions: motor, mental status, sensory, communication, feeding, and respiratory. And the final question was we asked to the parents' perception of the child's functional outcome. Did they feel at that point that their child had no functional impairment, mild, moderate, or severe? This is a close-up of the functional status score, and what I just want to point out to you, this is a validated score for use in a pediatric ICU setting. And so what's interesting about that is very severe dysfunction is indeed very severe dysfunction. You'll see for respiratory, for example, mechanical ventilatory support at all times. But even something like mild dysfunction under respiratory would be oxygen treatment and or suctioning. So for our results, the predictive value of these intuitions, any prediction of death you'll see was essentially no better than chance. But it did improve as there was agreement across the care team and additional days where there was agreement of prediction. So you'll see greater than 2 days death predicted, the positive predictive value was 67. And if there was a unanimous same-day prediction of death, that positive predictive value in this very preliminary analysis was 100%. When we looked at it across the different levels of providers, you'll see that residents and nurse practitioners, it was no better than chance in either predictive value or sensitivity. But that as you got to fellow and attending, the predictive value of these intuitions improved. When we did our 1-month follow-up with these 28 patients, we found that most of them had no functional impairment when measured on the objective measure, and that's to be expected. These were the first patients to be discharged, so they tended to have the least complicated course. When we compared the objective measure, the attending's prediction, and the parent's perception of outcome, you'll see that in over half of those cases, there was at least some disagreement across those dimensions, although in 11 cases there was no disagreement. So what we did was we looked at the attending prediction of functional impairment versus our objective outcome measure at 1 month. And what's interesting is that you'll see that the attendings tended to predict more severe functional impairment than we actually found at 1 month. And what's particularly interesting about this is that our attendings were predicting functional outcomes at 6 months, And our preliminary outcome analysis was only at 1 month. And you would expect that, that patients would get better over time. When we looked at the attending prediction of functional impairment at 6 months versus the parent perception of functional impairment, there was no directionality. And so what this really sort of showed me, and especially in conducting these telephone interviews with parents, is that the physicians and the parents may not be using the same baseline to talk about functional outcomes. And so that's something that I think we really need to address further. Limitations, obviously, especially with our preliminary study, there's a very small sample size. The assessment of dysfunction is subjective for the physicians, for the parents, and it also, we may need to use a different outcome measure than the one that's specifically designed for an ICU setting. Our follow-up population, there's a sampling bias in terms of who answers the phone and who's willing to speak with us. We were comparing physician 6-month predictions to 1-month follow-up, and it's a single center. Implications, the predictions of mortality are imperfect, but especially experienced clinicians, they may have some value. They have limited ability to predict functional outcomes. And again, parents and ICU clinicians may not use similar reference points when talking about outcome. And so that's something that we may need to address in training about how to have family meetings. Next step, short term, we're going to complete the analysis of our 6-month outcome, and we're going to evaluate additional parameters that may improve the predictive value of these clinician intuitions. Medium term, we're going to identify barriers to accurate prognostication and the needs of families regarding communication. And long term, we'd like to develop an objective prediction tool that can improve family and physician decision making and sort of try to alleviate that issue of everyone starting from different reference points. I'd like to thank Dr. Nidhi Pinto, who is in the back here, who was my mentor on this project, obviously the Bucksbaum Institute for allowing me to present and for support of this project, Tae-In Kim, who is our undergraduate, who's also in the audience, and everyone in the pediatric ICU who was so wonderful to work with.
Questions for Elizabeth? Holly?
Elizabeth, thank you for that wonderful presentation. I'm wondering, in your grouping of residents, did you differentiate between level of training, since a third-year resident may be more similar to a fellow than a first-year resident?
No, that's a really interesting question. So we had an advantage in that we were in the pediatric ICU and it's second-year residents. Now, we did have a difference between our residents who were at the end of June. So obviously they're the end of their second year versus our residents who were in July at the beginning of their second year, just off of intern year. But because we just had that 1 R2 year, we did not differentiate.
Peter? Jerry?
So in those phone conversations, the follow-up interviews with parents, I imagine some of those conversations, must be difficult, or the delicate. And any lessons learned about the language or the manner in which, those are tough questions to ask. How dysfunctional is your child now?
Yeah, no, I have to say, in terms of exemplars that we were talking about before, Dr. Pinto was a wonderful exemplar. We talked a lot about how to conduct the follow-up phone calls, and when we talked about we'd never use the term dysfunction. We used the term functional limitations and functional impairments. And actually what I found the most interesting was that some of the families who had the most severely impaired patients, because that was their reality and their reference point, they were sort of the easiest to talk to about it, whereas a patient who might have gotten a perfect score on our objective outcome measure, those were actually sometimes the most difficult parents to talk to, because they were looking at the difference between their child before this and after this. And so if their child gets 3 more colds this year than before, they're impaired. Whereas the person who's dealing with a child who's severely functionally impaired just has a completely different reference point.
In terms of predictive ability, how did your data compare to the NICU and the adult medical ICU?
So it was very similar overall in that we found that just any prediction was no better than chance. In our small data, we actually found that attendings and fellows were fairly good at the predictions, which was not something they had found in the NICU or the MICU. And I think we're sort of waiting to make a judgment on that until we can do the final analysis, because this was a very small sample.
You really did show amazing ability to predict fellows and attendings, which, as you say, was not the findings in the other two groups. Thank you so much. Wonderful.
Thank you.
Robert Sanchez, a graduate of Yale, where he majored in the history of science. After graduation, Robert was selected as a Congressional Hispanic Caucus Institute Public Policy Fellow in Washington, where he worked in the U.S. Senate in the offices of then Senator Barack Obama and Senator Ted Kennedy. Robert will be presenting his research paper entitled Shared Decision-Making Preferences and Behaviors of Hispanic and non-Hispanic white patients who have diabetes. Robert.
Thank you so much for the introduction. I'm very honored and excited to present my research with you all this afternoon. So I had the honor of having a mentor who is also a member of the Bucksbaum Institute, Dr. Monica Peak, and she's actually not here today. She's receiving a great honor from the Society of General Internal Medicine, so she couldn't be here today, but she's also a wonderful mentor that I've had for this project. So my focus on this project was on shared decision-making, and I think one aspect of this that we're all pretty familiar with is the decision-making aspect, the relationship between the patient and their doctor and their ability to come to a decision upon the treatment that they'll be receiving or the type of care that they'll be having moving forward. But another aspect that we feel is just as important is the information sharing aspect, and this kind of gets at how engaged the patients are and have taken an active role in sharing with their doctors. So this is the ability for patients to give information and ask questions and initiate discussions. So imagine a patient who might come into your office during clinic and ask specifically, doctor, I want to know how I'm doing with my HbA1c, or I heard that it's important to check my feet. I want to make sure that I'm doing this properly. So we feel like this is important in having engaged and empowered patients that we wanted to take into account when we look at the aspect of shared decision making. Of course, the next part is the decision making in and of itself, and this is the ability for patients to take an active and participatory role, not merely just sitting there in the patient's office, in the doctor's office, and hearing the doctor tell them what to do and just simply agreeing, but having an actual discussion. And what's great about this is that there's been plenty of research that says that this is beneficial. It's more efficient. Patients are actually more pleased with their doctors. They're less likely to switch providers or be unhappy. And it actually leads to better outcomes. Specifically in the realm of diabetes, we have improved diabetes control, lower blood pressure, and of course in diabetes control we're thinking about HbA1c levels and their overall outcomes in their care. So clearly this has a great impact. The next aspect that we wanted to look at is specific to the population of Hispanic or Latino Americans. The background on this is that Latinos and Hispanics typically experience lower quality of patient-provider interactions than the general population, or especially, as we'll be looking at in the study, according to their white counterparts. This contributes to health disparities, and it's something that we really wanted to take a look at. Specifically, Latinos in survey responses and different research said that they were less likely to be given control over their treatment options as compared to their white counterparts. This contributes to health disparities and also results in dissatisfaction and poor health outcomes, especially when you're looking at patients interacting with doctors who also speak of different languages. And one thing that's important to remember when we talk about this is that this is beyond just language barriers. These disparities in the quality of care were recognized even when proper Spanish language interpreters were being used. So something clearly more is at play here when we're talking about this population. Which brings us to the focus of our study. Our objectives of this study were to really explore these reasons behind Hispanics' low quality of patient-provider communication. And we wanted to look at two aspects, the patient preference for shared decision-making and patient involvement in shared decision-making. So the preference, whether being, are patients actually willing to be engaged in this process? And the patient involvement, are patients already doing some of these measures and we can already take account? Specifically wanted to focus on diabetes because there's a number of great reasons for this. There's ongoing treatment decisions when it comes to diabetes care. As you may know, we're talking about different kinds of treatment regimens, how patients respond to certain medications, and overall what works best for them in order to bring their sugars under control. This is an area in which racial and ethnic disparities continue to persist in this population, and it provides well-defined objective measures that we can use in our analysis, which particularly benefits this aspect when we're conducting our research. Our null hypothesis was that there would be no difference in shared decision-making preferences or practices between Hispanics and non-Hispanic white patients when it came to these objectives. Our survey was conducted. It was done in 2002 by my mentors, Dr. Monica Peak and Dr. Marshall Chin, and it took into account about 34 health centers across 17 states in the Midwest and the Central West region. And overall, we had over 1,000 patients participate in the study, in which about 47% were white, 26% were Latino, and 26% were Black or African American. And also another portion of this population were listed as other ethnicities, but these are the parts that we were focusing on. Specifically, I was focusing on the Hispanic and Latino population as compared to their white counterparts. So our methods for conducting this study is to now analyze the patient preference for shared decision making. We did this using a tool called the patient practitioner orientation scale. This is one that kind of looks at patients' interactions with their doctors and how patient-centered the care that they're receiving is. This is a Likert scale with 3 types of questions. A type of question that we'll be asking and I'll be talking about later would be, we provide the patients with the question statement saying that the provider should make all of the decisions responsible to their care. And then we'd ask on a scale of 1 to 5, how much do you agree? And the patient would respond. So this was based on a scale of 1 to 3, a total of 15, and if they scored less than an 8, they're described as a passive role, and if they scored a greater, they preferred more of an active role. Furthermore, we wanted to check out patient involvement in shared decision making, and we did this by specific quality measures. So it was a 6-item tool that we talked about initiating discussions about care. So if patients are going in and reporting that they initiated a discussion about their foot care or the HbA1c levels or things of that nature with their doctors as responded through this survey. And all of our data analysis was done through Stata. So the results of this survey. In general, we wanted to look at shared roles, in which we asked the patients a question about whether patients and doctors should be equal partners. And as you can see, there's an overwhelming agreement. Amongst all of the patients that we surveyed, over 93% of them agreed with this. So clearly they're on the same page between Hispanics and non-Hispanic whites. Next, we wanted to look at the actual patient preference for shared decision making, and this is on the Likert scale questions of the patient practitioner orientation scale, which I'll be presenting next. So here, you'll see in the top left, this is the statement that we'll be providing. And one of them, again, was the physician should decide what gets discussed at a clinic visit. Now, whereas whites, 71% of them disagreed with this statement, less than half of Hispanics disagreed with this statement. So this clearly had significance, and actually in all 3 areas in which we asked this question, there are significant results in the differences that we saw. So what we're seeing is that Hispanics are less likely to disagree with the passive role, a passive decision-making role when it comes to their care. So this is significant. And as we continue to analyze that, we're able to also note the differences between whites and Hispanics, that when we look at the odds ratio as compared to their white counterparts, Hispanics were less likely to prefer an active role in this engagement, which led to the second conclusion that we saw in this study, was that Hispanics were less likely to prefer an active role in shared decision-making compared to their non-Hispanic whites. We wanted to, now that we had an understanding of their preferences, which are significantly different, we wanted to look at what their actual involvement was in shared decision-making. We did this using the scale, asking how often in the past 6 months had patients been involved in initiating discussions about different measures from cholesterol, blood pressure monitoring, eye examinations. And as you can notice, there's actually no significance in the differences between these 2 populations, except for one measure in which foot examinations saw a difference. But overwhelmingly, when it came to initiating discussions, they were pretty much exactly the same. So whereas you're seeing a difference in the patient preference for shared decision making, when it comes to their actual involvement, there's no significant difference between Hispanics and their non-Hispanic white counterparts when it comes to these diabetes care measures. So this is a pretty interesting and kind of a complex implication that we're seeing. So this is a complex relationship. There's a preference for a passive role and kind of deferring to physicians, while Hispanics are just as likely to initiate discussions about their care measures. So since this is sort of complex, one of the implications we can draw from this is that this is a unique patient population which has different considerations that we have to take into account when we talk about shared decision making. Not all initiatives and the measures will be exactly the same or fit the same group. And so we have to take into account values of respect for authority that can happen in this group. And we also have to have appropriate engagement when we have shared decision making with this population. So making sure that it is culturally tailored and has the overall goal of improving care and reducing disparities. We had several limitations to this survey. So this was primarily done in the Midwest region, so that impacts our generalizability. And the community health centers that were involved in the survey were involved in an overall sort of improvement trial. So that might have impacted the level of care that our patients were providing. And also our initial survey didn't have any measure of English fluency or acculturation, which can definitely impact, especially the level of immigrant status or where the patients were in their setting of how long they've been in the country and things of that nature. So for our next steps, we are looking forward to continuing future studies which are warranted in exploring this complex relationship. Specifically, we'll be moving forward with qualitative research very soon. In fact, next week after I complete my Step 1 board, I'll be looking forward to overseeing one of the focus groups that we'll be having at Chicago Family Health Center, in which they'll be having a Spanish language discussion of a focus group looking at these specific issues based on the questions that I was able to develop this past summer. And this will definitely include an assessment of English fluency and acculturation, which we had mentioned might be a limitation before, but which we can continue to look at as we have these discussions with these patients. In closing, I'd like to acknowledge my mentors, Dr. Monica Peak and Dr. Marshall Chin, the support of their overall project in improving diabetes on the south side of Chicago, and lastly, of course, the Bucksbaum family and the Bucksbaum Institute for having me here today. Thank you so much. I'm happy to take your questions.
Robert's paper is open for questions and discussion. Arthur.
Those findings are kind of in conflict with each other in a way. I wonder if there's any way to verify whether what they said was actually true. They may have wanted to please you and said, well, we did bring this up with the physicians, but maybe in the encounters they didn't. So I just wonder if there was some objective way of evaluating that possibility.
It was very interesting to see those kinds of differences. I don't think, given the survey, there's a way to sort of really see if they might have just been trying to please. But I think what it is interesting is, given such a large sample size of over 1,000 patients, you saw this both with the white and Hispanic populations, that the trends were the same, especially on those initiating discussion levels. I think that gives it some power in saying that there is some sort of correlation there. What I was taking more from it is, in terms of their sort of preference in taking an active role, that might be most important as the key takeaway, because that means that whereas they recognize that these measures are important, if we want to empower patients or we want to get them more involved in these discussions because they do improve care, we have to make sure we do it in an appropriate way. Because whereas we might want patients to come into the clinic and have a whole list of things to say and really be prepared, that might not necessarily resonate with this population. So I think when we take that into account and making sure that we respect what they might feel is most important, how they want to interact with their physicians, and doing it in a nuanced and tactful way, I think can be pretty key in terms of how we do that. And the overall goal of this, which has been done with the African American population on the South Side, is having patient empowerment courses that really speak to that. So if we want to be able to have that with this population in our community, we really want to tailor it to what's most important to them. And that's what we've been able to really get a sense of in terms of this survey, in terms of these qualitative efforts that we'll be moving forward with.
Yes, please.
Great presentation. Start from me. So did you control for educational level, income, everything?
Yes, absolutely. We had a multivariate analysis that did take those into account. I didn't include it in this presentation, but did mention it in terms of our paper. There were interesting correlations in terms of involvement in shared decision making based on more factors than just the ethnicity, and that include a level of education, I think a little bit on gender, and also given the length of how long they had been patients at these particular clinics. So all of those were factors, but we're kind of beyond the scope of what I was presenting today, but also really important things that we take into account when we think about our patient care.
population you studied in Spanish, are they first generation or second or third? And do you think what makes any difference to us?
Absolutely. So the limitations for this study was that we actually didn't get a sense of where they were in terms of their level of acculturation. But one of the things that I looked at over the summer was getting a sense of what other tools are out there to measure acculturation, and which I was able to find one, and which we'll be including when we conduct these interviews and the focus groups for the patients that we were getting involved with, specifically at the Chicago Family Health Center. Those the tool mostly looks at not necessarily their length of stay, but specifically in language. For example, what language do you watch your local news in? That we find that those kinds of measures are actually a better predictor of their acculturation status in the country. And it's really interesting to look at personally for myself, as I'm about a fourth generation Mexican American. And so I recognize that there are differences from generations who have come before me or other families who might be more recent immigrants to the country. So it definitely factors into a play, and we definitely want to account for it when we look for it.
Picking up on Dr. Rubenstein's suggestion from a few minutes ago, or question about whether you could validate that what they say in the response is what they actually did in the clinical setting. Now that you're doing a new study, you could think about voice-activated recording systems that patients would consent to, which would give you the data on whether, in fact, they were initiating the kinds of raising the questions that your study looked at.
Absolutely. And one of the other aspects I'll get to do is actually interview some of the staff at these clinical centers, so we can actually get a sense from the providers about how often we're getting patients who are actually initiating this as well. So we can get the counter side as an addition to the great point that you raised about making sure that this is actually what's being reflected in the clinic.
Thank you so much, Ray.
Thank you so much.
The final minutes of our symposium today, I've asked two of our board members, Dr. Laura Roberts from Stanford and Dr. Arthur Rubenstein from the University of Pennsylvania, to join me up here for a brief discussion about the symposium and the Bucksbaum Institute.
So I remember exactly one of the things that I was most worried about was when was my first patient going to die? And my life had been touched by loss and death before going to medical school, and that's part of the inspiration to go into medicine. And so I go to medical school and I was terrified of when my first patient would die. Well, first year, second year, I went all the way at the end of third year, and I haven't had. Sure, part of it is that I'm hyper vigilant in trying to not let patients die because I was so defended. But so one day I was walking on the corridor and a patient called, "Nurse, nurse," and I responded because that was the time. And he wanted a bedpan, so I gave him the bedpan and I went in the washroom to wash my hands. And while I was in the washroom, he died. So it was just unbelievable experience to have that be my first patient who died. He was DNR, DNI. There was a team out in the hall. I brought them in. I was kind of panicked and overwhelmed. But it kind of burst something in me. You know, that was the moment when I'd had not even my patient, but a patient die with me. And that was the time when I started really thinking about what I said earlier about how our job is really not to prevent death, obviously. It's to help people bear the suffering, tolerate and deal with constructively the hand that they're dealt. And I'm reminded of a wonderful quote by Helen Keller where she says that the world is full of suffering, but it's also full of the overcoming of it. And in honor of the poetry, I know exactly one poem. I'm going to recite it to you very briefly. It's written by Emily Dickinson, and she wrote, "On the bleakness of my lot, bloom I strove to raise. Late my acre of rock has yielded grapes and maize." And it's such a perfect capturing of how patients, people living with illness, are trying to overcome their hardships. And we all know the extraordinary heroism and grace with which many of our patients live out very, very severe suffering. And so I wanted to underscore so many of the messages from today, which were very affirming of patients, the importance of being with patients in these hard moments, holding it with them, realizing that you don't have to be magical and make it perfect or make it cure things, but just the experience of being with another human being, and that is just incredibly powerful. So I thought that the darker issue that emerged in the conversations with the Golds yesterday and in Jerry's comments is if our education system is separating student doctors from patients, and they're not spending as much time with patients.
the inspiration and the lessons are not going to be shared. So all of you who raise your hand as being medical students, go sit with patients. I encourage you to, go beyond what the brilliant curriculum that I know is here, but go beyond it and spend as much time as you possibly can with patients, and be with them in their experience and live out that narrative with them, and be the person who sat with them and gave them the gift of at least attention and kindness, no matter what they're doing. I had another, just 2 points. One is, there was an earlier conversation today that many of the things that the Bucksbaum Institute is funding are things that would never get funded by NIH. And I really want to challenge you, especially looking at the examples from this afternoon. You can get funding for this work. You can get big funding for this work. There are techniques, there are ways you have to learn how to pitch it and how to work with it and what methods to use. But please don't defeat yourself before you've even begun. There are many, many ways, if this is your calling, to do studies of this kind of thing that would then contribute in a much broader way to the literature. And then the last thing I wanted to offer up is, no matter what stage of training you're at, no matter what stage of your career you're at, you are an example to others. So I want you to own your own leadership and the power that you have as role models and colleagues in inspiring others to be their best selves, and in looking for examples, counter-examples of good behavior in the environment, and in a very mindful way that was used earlier, very intentional way, reject the darker side and honor and live, live with the extraordinary inspiration that I think is here. And there's, I think the Bucksbaum and the Gold Foundations and other foundations that have really dedicated themselves to humanism and professionalism can really inspire us to do more. I think the reason it's been so successful is not just that you're amazing, and you are, but because there is a readiness, there's a thirst for this. There's another poem that talks about being thirst next to the fountain, and I think you figured out something that's really important to people, and they're ready and engaging with it. So to abandon the cynicism and nihilism and just and believe and continue to do this wonderful work, as we've seen with the magnificent work of the Gold Foundation and with your work at the Bucksbaum Foundation. So those are my comments.
So 5 o'clock on Friday afternoon, is it time for a long speech, isn't it?
Right.
I think the shorter I'll be, the more happy you'll be with my performance. So I'll be very short. So there seems to me just 2 or 3 comments I can make. One is, it is interesting to watch all this and reflect on what the mission of academic medical centers are. After all, here's the University of Chicago. I come from Penn. Laura comes from Stanford, represents the top tier of the top 10, 15 medical centers. And it was, I think, until the last decade or so, the belief that the really important things that these institutions could do is biomedical research. There was a feeling that that's how they should be ranked, that's how the recruitment should be emphasized, that's how the individuals would be thought about in terms of their major contribution to society. I think what's evolved and changed 180% degrees is no academic medical center can be worthwhile if it doesn't put patient care first. Everything can devolve from that, great education and great research, but if patient care is not emphasized and given the credit it's due, and given the kind of emphasis that makes an institution a humane and culturally acceptable institution, then all these other things seem to be rather hollow in my opinion. And I'd like to just say I was here 30 years, believe it or not, those of you who remember me, that coming back now and seeing what Kenneth, who's sitting there, Holly, Mark, which I take a little credit for the 3 of them, minimal, but some have accomplished in terms of creating this wonderfully vibrant and patient-centered, where the other things followed, institution, just gives me a lot of pressure. So I want to congratulate all of you. And the Bucksbaum Institute is just a really important reflection of that kind of attitude and vision for the institution. The other last point I'd make is, it ran through some of the discussions today, but it always impressed me that when one's looking after patients, there's so much to learn from poor and disadvantaged patients. When we're talking about humanity and professionalism and so on, those of us who really can think about what it's like, and there are plenty in this country, to be disadvantaged and not being able to really deal with society in a way that those with more money or opportunity or power have. It really gives a physician a unique opportunity to interact with these individuals and their families and to really make the best, you can ignore that, to really make the best of what one can see in humanity. And those of us who work in institutions, particularly in areas that are somewhat disadvantaged and have an opportunity to admit patients of that ilk, really should feel proud and advantaged rather than disadvantaged to be able to do that, because it does make the whole effort of medical care and what we're able to do at our very best a wonderful opportunity. So I think those are just two thoughts I'd leave you with. I think, as Laura said, the presentations were great. I think the Bucksbaum Institute, after a year and a half, is an enormous success. I think its impact on the institution will grow because people are invested in it, and I think we feel very privileged to be part of the advisory board, I guess we are.
Absolutely.
And I'm grateful to Mark and all of you for having us participate. Thank you.
Friday, 5:02. We came pretty close.
Not bad, eh?
Thank you all very much for